Good afternoon, everyone. My name is Brett McReynolds, the Vice President of Policy and Programs at the American Autoimmune Related Diseases Association. I'd like to thank you for joining our Managing Stress and Promoting Well-Being, Living with Chronic Pain webinar. At this point, I would like to hand it over to our moderator for the debate, Lily Stairs, who is Principal and Founder of Patient Authentic, and who is the Vice Chair of the ARDA Board. So thank you, Lily.
Thanks so much, Brett, for the introduction, and thank you all so much for tuning in today on this national webinar. Today, we're going to chat about managing stress and promoting well-being, specifically as it relates to living with chronic pain during the current health crisis that our world is facing. This webinar is designed for those living with autoimmune disease and chronic pain to hear from experts that can help them manage these issues during the pandemic. I am really honored to be your moderator today. I actually am an autoimmune disease patient myself. I live with several autoimmune diseases, which is what inspired me to get involved with ARDA and serve on the board. I am also a professional patient advocate and the founder and principal at Patient Authentic. And really, again, very honored to be here today alongside some stellar experts. We have Dr. Bob Phillips and Dr. Jack Kabasi. We're going to kick off today with Dr. Phillips, who is also known as Dr. Coping. He is the founder and director of the Coping Counselors at the Center for Coping in New York, and he is a widely published author and speaker on the topic of coping with chronic illness. He is also a fellow board member with me as part of the ARDA board, and he is truly one of a kind as a physician. So it's exciting to have him here today to share all of his wisdom and knowledge with us. So Dr. Phillips, without further ado, I'm going to turn it over to you.
Thank you so much, Lily, and good afternoon, everyone. I'd like to welcome you to my part of this webinar. Before I begin, I'd like to thank ARDA for putting this together. And I'd like to dedicate this webinar to the memory of Dr. Noel Rose, an inspirational physician and researcher, one of the founders of this organization. Although this webinar is sponsored by ARDA, the content of the webinar can be valuable for everyone. Next slide. Pain can affect everyone, not just those who are living with autoimmune diseases. One of the best ways to be able to manage stress and promote well-being is to be able to successfully cope with chronic pain. Pain is something that affects far too many people. And in this webinar, we're going to focus on strategies to help you to better deal with pain. Do you know how big a problem chronic pain is? Estimates are that millions, if not billions of people around the world experience chronic pain. Chronic pain is the top cause of disability in adults in the United States. It's estimated that 36 million Americans miss work because of chronic pain each year. There are many other statistics, but it can be too painful to listen to them. Next slide. Each person is different. Each person's perception of pain is unique. Each person experiences their own unique situation as to how pain impacts their quality of life. Given this, it makes sense to learn everything you can to see what you can do to help yourself better deal with pain. A recent survey taken by ARDA found that 60% of respondents rated their pain 6 or higher out of 10 since the coronavirus pandemic has begun. That, of course, does not reflect on what pain levels were for them prior to the pandemic, but it just shows that pain makes a difficult situation that much more difficult. Next slide. The impact of pain can be overwhelming, but it doesn't have to be. There are always things you can do about chronic pain. In the ARDA survey, more than half of the respondents are looking for new treatment options for their pain. The implication, of course, is that the old treatments are not working enough. You'll hear a little bit later from Dr. Kabezi, a physician who will be talking about pain medicine and multidisciplinary pain management approaches. In this presentation, we're talking about psychological techniques that can help your pain. Next slide. Before we get to some of the hopeful coping strategies, let's briefly mention the basic things that you should be doing if you're not already doing them. This obviously includes healthy eating, not smoking, getting appropriate exercise, resting, working well with your medical team, and properly using any medication that has been prescribed for you. All of these things can help you in your efforts to better manage pain. Next slide. So let's talk about some of the coping strategies that can help in dealing with chronic pain. There are a lot of different things that you can do to cope with pain. Obviously, in the amount of time that we have, we're only going to be able to briefly touch on them. But what you'll learn can at least serve as a springboard for you to learn more about the techniques that appeal to you. Your goal should be to learn everything that you can about how to control your pain or reduce it, so it does not have the same impact on you. Anything that you learn to do to better cope with pain will supplement the medical treatment that you're receiving for it. Ultimately, you want to learn how to better help yourself. Next slide. One of the first things to do if you're serious about learning how to better cope with your pain is to set up a pain management notebook. This way you'll be able to keep everything together in one place. Many of the most helpful strategies will work best in conjunction with your notebook. For example, you may want to write down your pain ratings. Write down the things that you're doing that lead to differences in pain ratings. Write down details and patterns about your pain, questions you may have about your pain, and ultimately the answers you get. Self-improvement goals, strategies you're going to try, progress with these strategies, and much more. It's a good idea to keep all of this in your notebook because you'll have it all together, all in one place. And it'll also help you to trace where you were when you started and compare it to hopefully where you'll be as you progress through your coping strategies. All of this information can be part of being a better self-advocate in trying to help yourself with your pain. Next slide. Relaxation techniques can be very helpful in dealing with pain. Relaxation techniques can help you physically as well as psychologically. The physiological impact of pain can be helped with relaxation techniques because it can reduce tension in your body, the tension which might exacerbate the pain that you're feeling. It also releases tension that may be increasing pain anywhere in your body. Psychologically, relaxation techniques give you something that you can do whenever you feel the need, which can help you to feel a little more in control. There are many relaxation techniques available. Each person can determine which techniques work best for them. But the most important thing is to try them. There are apps that can help you with relaxation techniques. Do a search in the App Store on your mobile device to find apps and try them. See which ones seem to work best for you. One of the techniques that I often teach is one that I developed called the quick release. This is a very simple but helpful 2-minute procedure that you can use as often as you need. I've recorded an audio file of the quick release and would be happy to send it to any of you who might like to try it. Just send me an email address. Send me an email at the email address that I'll provide for you at the end of my presentation, and I'll email it right back to you. In addition, if we have time at the end of my presentation, I'll teach you an even shorter relaxation technique that you can use right away. Remember, whatever relaxation techniques you choose, practice them so they become part of your routine. Remember also, the best time to practice relaxation is before you need it. Next slide. You may laugh when you see this caption. You may even be saying, I don't want to go to the movies during the COVID crisis. How crazy is that? But I'm not talking about going to a movie theater. I'm talking about going to the movies in your head or using imagery to help your pain. Imagery, also called guided visualization, involves creating pictures in your mind that can help you to better deal with a problem. For example, peaceful images can be very soothing at times of stress. But imagery can be much more than just the use of peaceful images. You can actually use images to directly counteract the experience of pain. Unfortunately, this webinar is too short to be able to go into detail about the ways in which imagery can help your pain. But there are many good resources that can help you to learn more about how to use these strategies. I'd recommend that you search online for ways in which you can use imagery to help with your pain symptoms. Next slide. When there are things that exist in your life that you cannot change, it's very important that you do the best you can to cope with them. This often involves working on your thinking. The way you think, both about your pain and your life, is an important factor in how you feel. Even if you feel that you can't change your pain, working on changing your thinking about your pain will help you to feel better. Negative thoughts about your pain can actually make you feel worse. Thoughts such as, I'll never feel any better, or I'm stuck feeling this way forever, can actually make your pain worse. Rewording your negative thoughts in a way that's more positive and realistic can be very helpful. So for example, instead of saying, I'll never feel any better, you could say, how do I know that I won't feel better? Isn't it possible that I will? So as long as it's possible to feel better, why should I convince myself that I can't? Keep track of your negative thoughts by writing them down in your pain notebook, and then respond to them directly in a more realistic, positive way. You'll be pleasantly surprised about how much this can help. Next slide. Do you believe that having a good sense of humor can help you deal with pain? It's true. There have been countless studies in the medical literature of people who have helped their painful conditions by laughing. In fact, a classic book by Norman Cousins called Anatomy of an Illness discusses how the use of humor helped him dealing with his own autoimmune disease, ankylosing spondylitis. Think of things that make you laugh. You may want to make a list of movies, television shows, books, comic strips, or anything else that you can think of that you find funny. Laughter truly is the best medicine, and it can help you both physiologically and psychologically. Next slide. Interacting with others is a very important part of life. The effectiveness of your communication can play an important role in your efforts to manage your pain. Strategies such as expressing yourself positively rather than negatively, being able to explain your pain rather than complain, and being able to constructively and assertively reach out when you need help are all important communication skills. Having a good support system is essential in coping with pain. Everyone benefits from having people with whom they can share problems and get support. The empathy and advice you get from others can be an important part of being able to successfully deal with your pain and reduce any feelings of isolation that your pain may have caused. This doesn't always mean that you'll get the support that you want or need, but every little bit does help. It's also important to be able to communicate well with your doctors. The importance of this was illustrated in the recent Art of Pain survey that we've spoken about, which indicated that more than 40% of the respondents complained that their doctors do not understand their pain. And talking about dealing with other people, it bears repeating the most important current reminders for taking care of yourself during the coronavirus pandemic. Next slide. Make sure that you maintain social distancing. Wash your hands often. Wear a mask and make sure you don't touch your face, and minimize any opportunity for you to be exposed to this virus. Next slide. So to wrap up my part of the webinar, know that you're not in this alone. Make sure you take advantage of all the possible resources that can help you in living with chronic pain. These resources include your support network, your medical team, mental health professionals, online resources, and so much more. In addition to benefiting from others, make sure you use your own coping toolbox to help yourself deal with your situation as best you can. Okay, I believe we do have time, so I'm going to teach you the relaxation technique I mentioned earlier. I call it the 10-second shoulder shrug technique. Let me describe it first, and then I'll guide you through it. The shoulder shrug technique involves taking a deep breath, and as you inhale, lifting up both shoulders as though you're shrugging your shoulders. Hold your breath and keep your shoulders up for about 6 seconds. Then let your breath out in a whoosh and let your shoulders collapse back down to a fully relaxed position. Allow your breathing to continue smoothly for the next few seconds, and that's it. You'll feel a difference. Obviously, if there's any medical reason, such as pain or a breathing problem, that you shouldn't either shrug your shoulders or hold your breath, don't do it. But listen anyway. Maybe the sound of my voice will be relaxing. Ready to try? Okay, here we go. Take a deep breath and lift up both shoulders. Hold your breath and shoulders for up to 6 seconds. Now let your breath out in a whoosh and let your shoulders collapse back down to a fully relaxed position. Allow your breathing to continue smoothly. Feel the difference? This, as with any coping strategy you use, can be modified to fit your needs. It's unfortunate that there's not enough time to dive deeply into these coping strategies, but these techniques are just the beginning. There's so much you can do. My goal was to present a series of ideas or tips that can trigger your creativity and help you learn about some things you can do to make up your own self-improvement program. This can benefit from both guidance and self-initiative. Your goal should be victory over pain. You may not be able to eliminate pain entirely, However, a victory is achieved for every bit of pain you can reduce or control, and dealing better with any pain that you can't. Next slide. Let me end my portion of the webinar with the motto of my psychology practice in New York. No matter what problem you may face, you can always improve the quality of your life. Next slide. Once again, I'd like to thank all of you for joining us today and to thank Arda for putting this all together. Thank you.
Thank you so much, Dr. Phillips. You really do have one of the most relaxing voices. And so every time you do the shoulder exercise, I feel so at peace. I'm going to have to listen back to the recording, and I'm just going to keep it on my computer so that I can force myself to do that every day. So thank you so much for taking the time and sharing all of these tools and techniques with our guests. All right, so I think we're ready to move on to the next section. And could we go to the next slide, please? Here we go. We have Dr. Jack Kabezi. He is the Vice Chairman and at the Department of Anesthesiology and Systems Medical Director at Allegheny Health Network Division of Pain Medicine. Dr. Kabezi works really closely with many autoimmune patients and with the Autoimmunity Institute out of Allegheny Health Network, which is a really, really special and unique place where autoimmune patients can get treated and seen by many specialists at once. ARDA is a big supporter of the Institute, and we often refer patients out there. So if you haven't heard about it, definitely check it out. They're based out of Pittsburgh. But Dr. Kabezi, I'm really excited to hear from you as a practicing physician and share some of your thoughts on managing chronic pain as an autoimmune patient. So I will let you take the floor to share your thoughts.
Thank you very much. Welcome everybody that is on the line. First slide, please. This is what I do for a living. I treat chronic pain patients every day of my life. We train other physicians here. We are at Allegheny Health Network one of the training facilities for physicians who move forward in their career and focus explicitly on chronic pain. A little anecdote, whenever my young niece, when she was in high school, I took her into the operating room with me, and I was doing a spinal cord stimulator implant for a patient who had severe chronic pain secondary to ankylosing spondylitis. And she was very interested in medicine, and she asked me how long it would take to become a doctor after she finished high school and practiced pain medicine. And I told her 13 years after high school, and she immediately said, I'm not going into medicine. So she's moved on to another career. I guess she didn't want to invest that much time. But chronic pain is a very challenging, not only for the patient, but also for the physician, regardless of the specialty that the physician is in. Next slide, please. So again, this is a difficult situation for both the patient as well as the healthcare provider who's attempting to take care of the patient's pain appropriately. And when we talk about chronic pain, we have to set reasonable goals and expectations. Our expectation is not to have their pain drop from a 10 to a 0. That's usually not a goal that we can meet. Sometimes it is, but most times it isn't. But what we're challenged with as providers, pain physicians, is to allow the patient quality of life and to be able to function in a reasonable pain-controlled state moving forward. Hundreds of thousands of adults in the country have to suffer with chronic pain, and around the world, 1 in 5 adults experience a chronic pain. The problem in treating chronic pain is that most physicians are not trained appropriately to treat chronic pain moving forward. And there are multiple things that we can do to treat chronic pain above and beyond a medication. Next slide. So this is pain medicine. This is what we do. The discipline of pain medicine is concerned with the prevention, evaluation, diagnosis, treatment, and rehabilitation of painful disorders. That's essentially what we do. I have a bias in regards to some pain physicians who will treat the pain in a patient with a intervention, but send the patient away if the intervention fails and send them back to their primary care physician or their rheumatologist or their immunologist and saying, well, I did a procedure on the patient and it didn't work, so I have nothing else to offer them. There are many other things that an appropriately trained pain physician can do to help chronic pain in patients that have immunocompromised situations. Next slide, please. This was an interesting slide I used in some of my talks. This is what Descartes envisioned chronic pain being. He thought that there was one nerve that left the extremity and went directly to the brain. And obviously, that's not the situation. Next slide, please. We know it's a lot more complicated than that, and there are 4 physiologic processes involving pain. If you look at this slide, you'll see the fire down below. Transduction, that's the chemical process that takes place in the limb or the area that the pain starts in. It's transmitted to the spinal cord. And the spinal cord is very, very important in the modulation process because we know chronic pain can take on a life of its own based on the changes in the spinal cord over time. And then it's sent to the brain, and perception is the last physiologic process in the pain pathway. And perception means how you perceived your siblings, how you perceived your friends, how you perceived your parents respond to pain. That plays a role moving forward in your adult life. Next slide, please. So the important point on this slide is inflammatory mediators. So inflammatory mediators are playing a huge role in chronic pain as it develops in the spinal cord as well as in the periphery. Next slide, please. Now, this is a rather complicated slide, and I only throw this up here to demonstrate how complex chronic pain can be. And there are multiple pathways on this diagram where we use not only interventions, but we use medications to essentially disrupt the pain pathways so that we can lower the pain in the patient. Now, when we talk about changes in the spinal cord, the pain pathway actually becomes very, very complicated because we know that over time, pain can become chronic because the pain actually then takes place in the spinal cord, far from the instigating incident that caused the chronic pain. Next slide, please. So, pain originates in multiple locations. I don't need to tell everyone on the line this is what they experience every day. Peripheral nerves, the spine itself. Viscera means organs, your internal organs. Muscle, joints, and the CNS is the central nervous system. Patients will come in and they have an autoimmune disease and they'll tell me their skin hurts. And why does my skin hurt? Well, because you have a chronic pain syndrome, and pain that causes your skin to hurt is called allodynia. And what does allodynia mean? Allodynia means a non-nauseous stimulus is causing a nauseous response, meaning light touch is causing pain. So we know that that can happen with autoimmune diseases in people who have autoimmune and pain. CNS dysfunction is a modifier and a sustainer. And what that means is that the pain actually takes a life of its own in the spinal cord. And sometimes we can mitigate pain in patients who have autoimmune disease pain by putting a spinal cord stimulator in their spinal column and overriding pain signals. Treatment of pain, there are multiple mechanisms why we use what we use, multiple medications, multiple interventions. And I'm going to talk about a little bit about multidisciplinary pain programs and the importance of moving forward in that direction. Next slide, please. So what does multidisciplinary chronic pain management mean? This dates back to the 1940s and to John Bonica, who was the father of pain medicine back in the 40s. He used a biopsychosocial model to treat pain, meaning we need to attack pain, chronic pain, from multiple directions. We need to use medication management when appropriate. We need to use physical therapy and exercises when appropriate. Cognitive behavioral therapy and techniques for pain and stress management, as you've already heard, are extremely important in our pain population, and procedures whenever it's appropriate. Next slide, please. So when we look at pain medicine and how we treat chronic pain, whether it's from autoimmune disease or any other particular problem that causes chronic pain, the multidisciplinary chronic pain management program has the strongest evidence compared to all other approaches. And what do I mean by all other approaches? Medications alone, psychology alone, interventions alone. If we use a multidisciplinary chronic pain program, it has the strongest evidence for success. In other words, the treatment success is better, it's cost effective, and it's low risk. Next slide, please. This was from the International Association for the Study of Pain. The problem in the United States is that we've gotten away from that model. So we had a very, very good model in the 40s and the 50s, but we've moved away from that model. And there's a reason for that. And unfortunately, much of it has to do with insurance and to some extent, physicians who have gotten away from that model. They have moved into interventions or they've moved into just medications, and they have not looked at the holistic model, the entire human being, and treating the human being as opposed to just the chronic pain. Next slide, please. So, balanced analgesia, when we're treating pain with medications, we've got many medications that we use. We can use anticonvulsants, we can use antidepressants, and if push comes to shove, in some instances, opioids are an appropriate treatment plan, but they have to be monitored and monitored closely because opioids are not without their side effects and their risks. Next slide, please. Interventional approaches. So I'm also trained in interventional pain medicine as well as medication management and addiction medicine. So what can we do? Ankylosing spondylitis was something that was brought up earlier. We can put in a spinal cord stimulator. If it is an arthritic issue in the spine, we can do nerve blocks that will work. We can lesion nerves. We can do epidural steroid injections. So there are multiple interventional techniques that we can do to help not only with the pain, but lessen the pain so that the medications that we use and the psychological interventions that we use will become more effective. Next slide, please. So this is a true multidisciplinary pain management program. And this is what we have at the Western Pennsylvania Hospital Allegheny Health Network program. And we're very fortunate. We started this program, and we didn't always have a true multidisciplinary pain program here. It takes a lot of funding to be able to do this for patients. Acupuncture, very, very successful. Medical massage, and I'm talking about a true medical massage, not just a Swedish massage or a deep stone massage, a true medical massage that is directed to the patient's pain problem. When it comes to acupuncture and massage, our acupuncturist and our medical masseuse like to bring the patient in at least for 6 visits in very quick fashion because they don't want to lose what they have gained. Essentially, if we schedule these visits a month apart, the patient may have lost what they've gained very quickly. So we bring them in perhaps on a weekly basis, and then we take a step back after 6 visits of each and see and gauge what the patient has gained in regards to pain relief. Behavioral health, we have a true pain psychologist here who sees the patient one-on-one, and we also have group therapy sessions every Monday in our office. And behavioral health has been a very, very huge boon to our patients. They have raved about what's happened here. Cognitive behavioral therapy has been a godsend to many of our patients. We have nutrition and weight loss. Unfortunately, many of our patients have poor nutrition, they're overweight, and they need help. And it's not enough to tell them to eat right, but they need help and they need guidance in that regard. Smoking cessation. We have a true smoking cessation specialist here, and we work to get all of our patients off of cigarettes. I always tell my patients, if you're smoking, you're paying someone to hurt you. And at the cost of cigarettes today, I'm not sure how patients can afford it. Whenever a patient is reluctant to stop smoking, and if I can't address it from a health standpoint, I try to address it from a financial standpoint, because if you buy a pack of cigarettes every day at the cost of cigarettes now in the United States, you're probably looking at maybe $3,300 in cash every year that you could be putting in your pocket. So many instances, patients don't look at it from a financial standpoint unless you break it down over the course of a year. And everyone will take a step back and say, wow, I didn't look at it like that. So it can work to some extent, but if they're having a difficult time, and smoking affects every single organ in the body. So smoking cessation is one of the biggest things we can do to help our patients in that regard. Medical marijuana. In the state of Pennsylvania, there are over 20 indications for medical marijuana. The number one indication in Pennsylvania, and actually across the nation, is chronic pain in adults. We've certified through our program approximately 775 people for medical marijuana. The vast majority are doing extremely well. If the patients that were on opioids, we've been able to lower their opioids by 77% over the course of a year, and we've kept approximately 200 people from even starting opioids, and they've done remarkably well on medical marijuana. It's not for everyone. It is a drug, and it is a medication that can cause issues if it's not monitored appropriately. But we've had very, very good success with medical marijuana. Virtual reality, we just started doing virtual reality. We send our chronic pain patients home with a virtual reality kit that they take home and they use for 3 months, and they use it on a daily basis, and we track the outcomes as to their pain scale on a weekly basis, and then they come back to our office and we discuss how they've done over the course of 3 months. Medication management, we touched on that very briefly. There's non-opioid medications, and there are opioids whenever they're appropriate. But if you're putting a patient on opioids, they have to be monitored very, very closely. Fluoroscopically guided interventions, we mentioned that, and then spinal cord stimulator implantations for a select few people who we believe will benefit from a spinal cord stimulator implant. Next slide, please. I don't want to overlook exercise. There was a very nice column in the New York Times not too long ago, and it talked about the 26.2-mile fountain of youth. Now, I'm not advocating everybody run a marathon, but clearly, exercise is a medicine. You have to remember to start slowly when you're beginning an exercise, monitor your pain scale. If you're exercising and you get your pain scale increases by 2, you need to cut back on your exercise. But exercise should be looked at as not only a medicine to lower your pain, but also help you psychologically and mentally as well. Next slide. And this is what we're trying to accomplish: rehabilitation, pain control, psychological treatment, and functional restoration. Thank you for your time, and I think I'm done.
Thank you so much, Dr. Kabezi. That was such a thorough and interesting presentation, and to learn about everything that is being done to support patients to help with pain is really remarkable. And I think, I know for me, it gave me a lot of hope as somebody who has in the past dealt with chronic pain. I've been very fortunate for a number of years now to be in medically controlled remission from my autoimmune diseases. But when my diseases have been active in the past and I've been in a flare, the pain is really unbearable. And so I think that hearing from Dr. Phillips and now you, Dr. Kabezi, how we can take the behavioral and the mental and marry that with the physical to really treat chronic pain holistically, it's I think really encouraging. So thank you to both of our expert panelists for that. And now we are going to move into Q&A, and this Q&A actually comes from the questions that many of you submitted when you registered for this webinar. But first, we just want to talk a little bit about some of the results we also ran from a survey we did. If we could go to the next slide, please. So chronic pain, and this is largely why we held this webinar, is because there are so many patients who are experiencing chronic pain living with autoimmune disease. And 86% of respondents said that chronic pain not only causes sleep disruption, but also decreased quality of life. And you can see some of these really startling statistics here, that it's impacting quality of life, and it's also a huge cost burden that many patients are bearing. So, we want to continue to do what we can at ARDA to help support patients who are living with chronic pain. And so we always welcome your thoughts and suggestions and ways that we can help do that. We hope this webinar is certainly a step in the right direction. So let's go up to some of the questions that we had. Next slide, please. Yep. Okay. Awesome. So, all right, here are a couple of questions that we received. And so I think I'm just going to go right from the top left corner here. And let's start with you, Dr. Kabezi. Could you talk a little bit about some of the websites or apps that you've seen used to help handle stress and pain?
One of the best ones that are out there is the American Chronic Pain Association. There are many tabs that you can go to off of that website that will help patients with chronic pain handle stress and will guide patients into an appropriate treatment plan for pain relief, and providers who are qualified in the specialty of pain medicine.
If I can add to that, there are so many apps that are available that it makes sense to be very careful before you select an app that you're going to use. Look for the ratings, look for the comments, and then experiment.
Thank you both so much. Those are great recommendations. And Dr. Kabezi, I know opioids are a big topic of discussion within the autoimmune community and those who are living with chronic pain. Could you talk a little bit about how have limited opioids affected chronic pain treatment?
Well, unfortunately, the chronic opioid issue, it started back in the late 80s and 90s, and it was sort of like a runaway train at that point in time. And physicians in general, not necessarily pain physicians, but most physicians were overprescribing opioids. I don't need to go into the opioid crisis that we experienced the last decade. And then there was a backlash, and physicians stopped writing for opioids. And unfortunately, many patients who have chronic pain and have an autoimmune disease and have a true, what we call in the pain world, a true pain generator, were, for lack of a better term, left out in the cold because physicians did not want to write for opioids anymore. They were concerned from multiple directions, not just medical legal, but were they monitoring the patient appropriately. So any patient who is in the autoimmune program or institute that requires an opioid comes to us, and we monitor the patient appropriately. Unfortunately, many of these patients were started on opioids, appropriately so, and the doses continued to escalate as patients and doctors did not understand tolerance and dependence. And when they got to our doorstep, they were on massive doses of opioids, and our job was to try and lower the opioid dose, if we could, to the most effective dose. So we treated the patient in a multidisciplinary program using acupuncture, using massage, using behavioral health, using interventions when appropriate. And what we found, if we intervened with all of the other multidisciplinary avenues that we have, and I showed on a previous slide, we were able to get many of these patients off opioids. And if we couldn't get them off of opioids, we were able to lower their dose significantly. And many of them had improved quality of life. So opioids are not a bad thing. Opioids are a good thing in a select patient population as long as they're monitored appropriately, and as importantly, the patient understands what goes along with chronic opioid treatment, meaning the possibility of addiction, tolerance, and dependence, and being monitored appropriately. But opioids do have a role in treating chronic pain, and specifically treating chronic pain in patients who have an immune disease.
Thank you. And I just wanted to make note that we do see your questions coming in, and we are taking note of those. So we will try to get through as many as we can in the time we have left. I'm going to jump around a little bit here. We've had the question, how limited should I be during COVID due to my autoimmunity? Should I go about my normal chores as others without autoimmunity do? So I think this question is very dependent. First off, I'll say that when we look at Dr. Phillips had in his presentation, we should all be wearing a mask and, regularly washing our hands and staying socially distant as the guidelines from the CDC have been released. We should be all following those, whether you have an autoimmune disease or not. I'll speak as an autoimmune patient myself who's in remission. I try to balance out, staying safe and staying socially distant and wearing a mask, but also will participate in some activities like outdoor dining or socially distant walks with friends. So I made that decision with my physician. I recommend that you speak with your physician, whether that be a gastroenterologist or a rheumatologist or whoever it is you see, or your PCP. Have a conversation with them to figure out what is best for you. And so then if we look at how to deal specifically with stress while parenting teenagers during COVID, while also dealing with my own stress of autoimmune conditions, Dr. Phillips, I think that's a great question for you to speak to.
Both of those situations are very stressful. The combination of both of those situations compounds how stressful it is. What you want to try to do is to separate the issues that are causing the stress. What are the specific ways in which parenting teenagers is stressful for you? Try to identify the specifics, because then you can try and plan a strategy to deal with it. Separate that, compartmentalize by focusing on your own stress as well. And try to have conversations. We talked earlier about communication. Try to have conversations with the teenagers so that they are better able to understand what you're going through, and at least you have time to yourself to be able to deal with your own stress. But any of the stress management techniques that can help you deal with any stressors in your life can be addressed by using coping strategies.
Thank you, Dr. Phillips. And then finally, wrapping up the questions on this slide specifically, we have a question about that this person wants to actually speak to their doctor instead of through gatekeepers. Is there a way that they can do this?
Dr. Kabezi here. So we have set up, and I think most doctors or physicians or healthcare providers have a way of getting a message directly from the patient to the physician. It bypasses the secretaries, it bypasses the nurses, and we have something at Allegheny Health Network, and I think that my colleagues at the University of Pittsburgh have the same thing. We have what's called a My Chart, and the physician can get a message directly from the patient that the physician has to look at, because he or she has to sign off on it. And therefore, I get messages from my patients on a daily basis. They ask me questions, they have concerns, and I can actually email them directly back and answer what their question is or their concern is, and tell them what we need to do, and perhaps get the patient in much sooner. So I would like to think that most healthcare providers provide that source of communication to their patients, but I know we do, and I'm sure that our colleagues over at UPMC do that as well.
Thank you, Dr. Kabezi. So now going through some of the questions that we've had come in, we did have somebody ask why they're getting really terrible pain even after having a cortisone injection for hip pain. And Dr. Kabezi, I'm not sure if you have any thoughts on that.
So self-disclosure, I've had a hip injection myself. I'm 68 and I have pretty significant arthritis in my hips. And so I don't know how the procedure was done, but an appropriate hip injection has to be done under fluoroscopic guidance so that the provider, hopefully the physician, can see what they're doing in real time. the needle goes into the hip, and there's a lot of pressure on the injection. The steroid, however, will take about 3 or 4 days to hopefully work. The question here is how bad is the arthritis in the patient, and we don't know that. But if it's bone on bone, probably the procedure is not going to help much. If the procedure wasn't done technically well, then the procedure is not going to help the patient. But it's hard for me to answer why the patient, or to the point, the person who's asking the question, why they had significant pain after the procedure. But certainly they want to follow up with the person who did the procedure and ask that question.
Thank you. That was a good answer. So this is another question, and we've actually seen this come up a couple of times. Why is my pain always worse at night?
Dr. Phillips may be able to chime in on this as well, but I see that on a daily basis, and I'll try and explain this very quickly. I don't believe in multitasking. I believe that you can do one thing very, very well, or you can do multiple things at one time and do a bunch of stuff poorly. I tell my patients, because they all come in and they say, my pain is always worse at night. Because you're otherwise distracted, your brain can't do many things at one time. It can do one thing at one time. And during the course of the day, patients are otherwise mentally engaged, and they're really not thinking too much about their pain. But when they're trying to relax at night, it's not like their pain miraculously goes away during the day or gets better during the day, but they're otherwise mentally engaged, and I'm sure Dr. Phillips can comment on this. But at night, you're trying to relax. You're trying to perhaps have a quiet dinner, or maybe watch TV, or even go to sleep, and you're not focusing on other things, and all of a sudden, you have nothing else to focus on but your pain. So distraction techniques work very, very well with chronic pain, but if you're not distracted, your pain feels worse.
I agree with what Dr. Cabezi is saying. In addition, for many people, pain is cumulative. So if you think of all the things that you've done during the day, each thing that you do during the day is just adding to the total accumulation of pain experienced during that day, which makes it that much more difficult at night. In the morning, yes, there can be some pain, especially for people who are dealing with arthritic type pain, where the joints seem to tighten up, synovial fluid slows down, etc. But as the day goes by and you're doing more and more things, sometimes it just builds up to a very, very painful state at night. Also, keep in mind that the pain may be building up during the day, but you may be less aware of it because of, as Dr. Cabezi said, the distractions that are in your life. And when the distractions go away, all of a sudden, whoop, there it is.
Great answers. Thank you both. Dr. Cabezi, a question, somebody is inquiring a little bit more about the virtual reality kit you mentioned. They've never heard about it in respect to pain management and are curious to learn a little bit more about what it entails, if you're able to share.
I can share a little bit. It's a pilot study that we've got going on right now. We have 10 patients, and we're looking at different pain generators. In other words, we're looking at autoimmune pain, we're looking at primary osteoarthritis, we're looking at patients who had multiple back surgeries and have what we call post-laminectomy syndrome. We're looking at patients who have fibromyalgia. So we have a cross-section of 10 patients, and we're in the midst of this pilot study right now. And virtual reality, it's an amazing device. It will really take a patient into another area, another country, and depending on what the patient happens to be feeling at that time, keeping in mind, when someone has chronic pain, there is always a component, and Dr. Phillips I'm sure will agree with me, there's always a component of depression and anxiety that goes along with that. So not only are we trying to lessen their pain, and sometimes it's just a matter of lessening their anxiety and depression that results in lowering their pain scale. So I would like to give you more information on that, but this is a pilot study that is ongoing, and I'll have more information hopefully within a couple more months, and maybe we can touch base again and I can talk more about it.
Yeah, that's great. That's really exciting. Thank you for sharing that. You know, and I would encourage folks to take a look and look for research studies or trials like this one. I mean, this is really how we get new treatments to market. And so, you know, I think that's an exciting way to look at how you might be able to treat your chronic pain. And, you know, there are a lot of different facilities and research institutions and hospitals that are actually engaging in some of these research studies and clinical trials. And you can sign up for ARDA's RNet, and that's our research focused arm where you can sign up and we'll let you know about studies that could be a fit for you near you.
Lily, if I can jump in for 1 second, I'd just like to build on something that Dr.
Yes,
Casey
absolutely.
talked about. There are a lot of people who are not aware of how much the emotions play a role in determining a person's overall pain. When they focus on pain, especially when they've been living with chronic pain, they tend to focus on the physiological component. What's going on in the body? What part of their body is in pain? And if somebody suggests, well, maybe it's because you're anxious or maybe it's because you're depressed, in a way they get uncomfortable thinking people are saying it's all in your head. Well, yes, it's in your head because that's where your brain is interpreting the pain that you're feeling. But there is a physiological and psychological component in virtually any type of pain that we experience. And while you're working with your medical experts to deal with the medical components, the physiological components, everything that you do to reduce stress, to reduce anxiety, to alleviate depression, to help you to feel better emotionally, is going to have a concomitant benefit to the overall perception of pain that you're experiencing. So it's well working on everything in order to reduce your pain.
And I agree completely with what Dr. Phillips just said. And if you go back to that one slide I showed about the 4 parts of pain, perception was the last component, and that's an extremely important component.
Okay, great. And I think we'll probably just do one last question here as we're almost at the top of the hour. And I'm actually curious about this myself too. We had someone write in asking about stimulus implantation near the vagus nerve plexus. Who is recommended for this treatment, and what does it do? And when is it not recommended? And that's kind of a big last question to end on. But Dr. Cabezi, I'm wondering if you can speak just a little bit to the vagus nerve stimulator implants themselves, because I know that those are in some studies currently for patients with autoimmune diseases.
I have a couple patients who have vagus nerve stimulators, and they have been very successful, but it is an intervention. It is a surgery, and it's been shown to help with visceral pain. And the studies are ongoing. I can't specifically, off the top of my head, tell you what the results have been, but the patients that I have seen in my practice have done quite well with them, but it's only a handful.
Thank you so much. And so thank you both for taking the time out of your very busy schedules and the patients that you're treating to chat with us today and provide insight. We thank you all so much for joining us. I hope that you learned a lot today and have some really concrete takeaways that will help to support you in managing your chronic pain now and in the future. Thank you for attending, and please know that we will have a recording of this presentation. So if you want to send it along to any friends or listen back, you'll be able to do that and check out more resources on our website at www.arda.org. Thank you all so much. Please stay healthy and safe and enjoy your weekend.